Good morning. I'm Dr. Vidhya Manohar, working currently as a locum consultant histopathologist at the Norfolk and Norwich University NHS Foundation Trust, England. I want to first thank SciTech Central Conferences for organizing this World Summit in Microbiology, Immunology and Infectious Diseases and giving me this opportunity to present a case report of a rare tumor, which is also a great mimicker in many aspects on this virtual platform today. Moving on to the case history, I would like to first bring to your kind notice that this was a case which presented during my practice as a consultant histopathologist in India, and I have relocated to England about 2 years ago. Moving on, a 40-year-old otherwise healthy woman presented to the outpatient department with vague upper abdominal pain of 6 months duration, and she underwent per abdomen examination which revealed a fullness in the left hypochondrium and the left lumbar region, which was also extending into the epigastric area. She subsequently underwent laboratory investigations including hematology and also imaging. The laboratory investigations and hematology were unremarkable. With respect to imaging, she first underwent plain CT study, which revealed a hypodense lesion with chunky coarse calcification and surrounding fat stranding. She subsequently was referred to undergo contrast-enhanced CT of the abdomen, which revealed a 12 into 12 centimeter well-defined heterogeneous mass in the lower pole. I have the images for that. Here you can appreciate the large heterogeneous mass in the left kidney, which was arising from the lower pole, and which also showed resultant hydronephrosis of the upper calyces, which I have tried to highlight with the arrow due to compression of the ureter by the tumor. With this large size and heterogeneous enhancing mass with patient having symptoms of compression and pain, the preoperative working diagnosis was a malignant neoplasm arising from the kidney, and most common being an epithelial neoplasm that we encounter in our practice. Our working diagnosis was a renal cell carcinoma. She subsequently underwent left radical nephrectomy, and this is the specimen that we received in our laboratory, which weighed about 310 grams, measuring 160 by 90 millimeters in maximum dimensions, and the attached ureter was 70 millimeters long. On cut section, the tumor was very well circumscribed, measuring 140 by 90 millimeters. That was indeed very large, and it had a very tan to gray-brown mahogany colored with a very spongy texture to it, which was abutting the renal capsule without invasion. Now what really caught my attention was the appearance of this tumor, which almost looked lung-like to me for a histopathologist who also does respiratory pathology and receives lobectomies. This looked like lung to me when I first saw it, but indeed it was there is a surprise ahead waiting for us. Microscopy. So I took adequate sections from the tumor kidney interface and the normal kidney. The image to the left that you can see is the tumor with the adjoining normal kidney. In fact, the star that I have marked shows the normal kidney, and one can appreciate that this was a well circumscribed unencapsulated neoplasm with a sharp tumor kidney interface in most parts. The image to the right shows the tumor, which has a very diffuse pattern but is comprised of small vascular channels which are almost capillary sized and appear sieve-like, and they have a very anastomosing or a maze-like network, almost looking like a sinusoidal architecture. And one can remember from their histopathology, from their medical school, a sinusoidal architecture anastomosing vessels is seen in the spleen. So that hence the name, the great Mimicker. On hyopa of this of the microscopy showed small capillary-sized vessels, which I had highlighted in my previous image, lined by a single layer of bland endothelial cells. They almost looked very banal to me, and they had a very hobnail appearance to it, meaning the nuclei was projecting into the lumen of the vasculature, giving it a hobnail appearance. Along with that, one can also appreciate there was extravasation of red blood cells into the surrounding stroma. And I've also tried to highlight these larger cells that we saw haphazardly distributed, scattered amidst the tumor. The larger cells had a multilobated nuclei and was resembling megakaryocytes, along with cells that had a more eosinophilic, dense cytoplasm, which looked like the myeloid precursors that accompany megakaryocytes. And in fact, one could tell that this almost mimicked a bone marrow that we were looking at. So amidst the tumor, we also saw evidence of myeloid and megakaryocytic lineage, which shows that there is extramedullary haematopoiesis that was ongoing in the tumor. Other microscopic features that was present in the tumor included hemorrhage, calcification, hyalinization, and sclerosis. They're non-specific features. They do not point to a particular diagnosis, and I did not take photographs of the same to show you. The negative points that I did notice were there was no mitoses, whether typical or atypical. There was no necrosis. There was no pleomorphism. There was or any multi-layering of the lining cells or hyaline globules. We further went on with immunohistochemistry. Now, before I move on to this, with this, our working diagnosis on microscopy was a vascular neoplasm of the kidney, which was fairly well circumscribed. It did not show any high-grade features or features suggestive of malignancy. So we did think of hemangiomas of the kidney, right? But we weren't sure, because you can have some very low-grade vascular tumors which can have no features, overt features of malignancy, but can be locally aggressive. So we went ahead, and we also didn't want to miss a epithelial neoplasm, which was the initial preoperative working diagnosis. So we also did a pan-CK to rule out that. So the image to the left, that's 2D, shows myeloperoxidase, which is an immunostain which highlights the maturing myeloid series in the tumor. You can clearly see some of the cells have taken up cytoplasmic myeloperoxidase staining around those larger cells, which in fact looks beautiful in this, which because of the negative stain, you can see they are megakaryocytic type of cells. The image to the right is a vascular stain, that is CD31, which highlights the endothelial cells, and these endothelial cells make up the tumor vasculature, right? And in the inset I have is the negative pancytokeratin staining, confirming that this is not an epithelial neoplasm. Yes, so we did make a diagnosis of an anastomosing hemangioma. At that given point in time, we felt this way. Yes, it's not cancer, it is a benign neoplasm, because our Ki was also less than 2 to 3%. Of course, I do not have the image for that, but you have to trust me on that. But yes, today's world, I think patients do walk into hospitals and are far more relieved to know that they do not have COVID rather than cancer. I'd now like to move on to the discussion and give you points of importance about this entity. Anastomosing hemangioma is a variant of capillary hemangioma, first described by Montgomery and Epstein in the year 2009. Yes, it was very recent, in fact, just about a decade ago. And the term is derived from the unusual sinusoidal or the maze-like pattern like I showed you, which is almost reminiscent or semblance to the splenic parenchyma. AH has been unique, and kidney being the most common solid organ to have shown the clinical presentation of AH, but other body sites have also been recorded to show AH, including the liver, the adrenal gland, soft tissue such as the thigh and the abdominal wall. And as I present this case, I can tell you there are less than 50 reported cases of renal anastomosing hemangioma in published English literature. So it is still a very new entity for clinicians and medical professions worldwide. With respect to the cases that have been published, I have had the opportunity to go through a few of the case series. In fact, the most recent being in 2017 by Pedrici et al. And also by Adnan et al., where they have compared the data with respect to anastomosing hemangioma case reports. And there has been a notion that this is most common in to have been seen in males compared to females, with the median age of presentation being about 50 years. And majority of these cases have been asymptomatic and have been detected incidentally during clinical examination or on imaging done for some other reason, or for patients who have come in for a routine health check. When symptomatic, the varied symptoms include hematuria, abdominal pain, like which was the case in our patient, and of course symptoms of urinary tract infection. So some cases published in literature have also shown to be multifocal. Now, multifocality or unifocality have not proven any significant pathogenesis. At the same time, some cases have also known to occur in end-stage renal disease, but there is no proven hypothesis to support that ESRD is a predisposing factor for anastomosing hemangioma. With that clinical background, moving on to imaging, as we saw in our own case, imaging CECT of the abdomen in these tumors have shown it to be a solid, well-defined, heterogeneous mass with enhancement on contrast. Now, one can argue that there is no difference between this and what an epithelial neoplasm, which is far more common in the kidney, can look like on CT imaging. So, yes, the radiologist should consider AH in the differential diagnosis of any vascular renal mass which shows enhancement, but that can be extremely difficult to pinpoint and be certain just on imaging about the diagnosis of an anastomosing hemangioma. In fact, with respect to vascular tumors of the kidney, there have been about less than 300 reported cases worldwide in literature, out of which 1/10 have been angiosarcomas. And like I mentioned earlier, I like to reiterate, now this is a fairly new entity with less than 50 cases. So I believe this opportunity of being able to present this case was also to help familiarize clinicians and medical professionals about this entity. Majority of the cases that have been presented and published in literature have known to occur in the hilum of the kidney for some reason, but of course other sites such as the medulla and the cortex have also been have shown the tumor. In our case, it was cortical and it was involving the lower pole. To reiterate again, macroscopically, these tumors are red, brown, mahogany colored, very spongy, almost looking lung-like in consistency. And microscopy, it has this angiomatous anastomosing vasculature in a very diffuse pattern, lined by a single layer of banal-looking endothelial cells, and hobnail morphology is a common feature. I'd like to also stress upon certain histologic variations which can occur in this tumor, and one needs to be aware so as to not to overcall a lesion to be malignant. And one of the most important pitfalls of this tumor include a focally infiltrative pattern with entrapping of the renal tubules. Now, this can be very confusing for a histopathologist because the moment I see infiltrative lesions, I'm always thinking of a malignancy or inching towards a malignant neoplasm or a locally aggressive neoplasm. Now, AH cases in some reported cases have shown this pattern, and one needs to be aware. The second being angiomatous spaces of cavernous type. As my definition said, this is a capillary hemangioma. One can also see intermingled larger vessels within this tumor, which can make one think of a cavernous type of a hemangioma. So one needs to appreciate the predominant vascular type and see a few other cavernous type in these lesions. Apart from those, the third being stromal changes such as fibrosis, sclerosis, myxoid change, calcification can all be seen in this lesion and are usually non-specific features. Extramedullary haematopoiesis, the fourth, is a very important pointer towards a benign lesion. Again, we were lucky to have this in our case because we have never seen a case of angiosarcoma showing extramedullary haematopoiesis, right, in the kidney. So this is actually a boon if you have it in your tumor. Hyaline globules are intracytoplasmic eosinophilic deposits, and ultrastructurally they have been shown by Kravchenko et al. That they are lysosomal aggregates. Now these are PAS positive diastase sensitive deposits, and they are not specific for anastomosing hemangioma and have been seen in other lesions, which I will be explaining in my next slide. Intravascular thrombi may be seen in these lesions along with stromal inflammatory cells such as plasma cells, lymphocytes, and mast cells. Differential diagnosis. Yes, we need to consider other vascular tumors and most importantly exclude malignant vascular tumors in this instance. Angiosarcoma being one of the most common differential diagnoses. Like I mentioned, it has a very infiltrative margin, and one needs to be careful and cautious when interpreting focally infiltrative margins of AH. The other signs of malignancy such as nuclear atypia, pleomorphism, multilayering, mitosis, necrosis will be seen in angiosarcoma. I have an image of a characteristic lesion in my next slide. I'll come to that. The points that I have highlighted in red font is to show you that these can be overlapping with AH and should not be confused. The second lesion which should be considered is a Kaposi sarcoma, which we did because at places it had a slit-like architecture, but Kaposi sarcoma are known to be HHV8 positive and also show an increased incidence of plasma cells as the inflammatory cells. The third entity is the papillary intralymphatic endoendothelioma, also called the Dabskar's tumor. It is an intraluminal papillary tufting of the tumor, which is very characteristic in this. And again, in this tumor, you will see a lot of hobnailing, and one should not get confused with a AH. Other benign lesions to consider include angiomyolipoma and deep splenosis. The reason why I'm talking about angiomyolipoma is some reports have also documented entrapped mature adipocytes within the tumor. So one can get confused with the angiomatous component and if the stroma is showing some smooth muscle differentiation and when you can see adipocytes. So one needs to identify and appreciate this anastomosing vasculature to differentiate it from AML. And deep splenosis, of course, we will be looking at white pulp and red pulp, which was not seen in this case, apart from the classical anastomosing vasculature. So these are just a very prototypical images of an angiosarcoma. You can see very high grade angry looking nuclei with multi-layering, prominent nucleoli. Coming to Kaposi sarcoma is essentially an atypical neoplasm. It's indolent but can be locally aggressive. They are comprised of atypical spindle cells lining the slit-like vasculatures that I talked about. Moving on to Dabskar's tumor, they are intrapapillary tufting of the tumor cells into the vascular lumen that you can see with hobnailing that I just mentioned. So my concluding points include anastomosing hemangioma is a rare vascular tumor with a proclivity for the genitourinary tract with unknown pathogenesis. A preoperative diagnosis can be elusive with known pitfalls, like I mentioned, including radiology. The kidney, being a very highly vascular organ, shows distinctive clinical and morphologic features, and vascular tumors in this location still remains obscure. The distinctive histology of this lesion, with semblance to splenic sinusoids, proves pathology to be the modality of diagnosis, although I mentioned it's a great mimicker radiologically, macroscopically, and microscopically. There is indeed growing knowledge of this entity in the last decade amongst clinicians. However, a better understanding of this entity is essential to offer optimal treatment options, which can range from just a diagnostic biopsy and no treatment to asymptomatic cases, to cases which are large and symptomatic, which can be amenable to surgery. With that, my take-home points include: this case was presented on this platform for various reasons. One, it was the first case reported in Indian literature with a unique lower pole presentation and a large tumor size. In fact, when this case report was first written out, I remember starting to write this in the year 2017, and there was not a single report from our Indian subcontinent. Although the differential diagnosis can vary from seemingly benign innocuous lesions to malignant tumors, with various pitfalls in its diagnosis ranging from clinical to radiology to microscopy, one needs to be aware, and the aim of presenting this case was to help enable better understanding of this entity and to create awareness and offer better decisions to the patients. I'd like to just show you the case report that was published. I'd like to thank my team on this occasion for being supportive and instrumental, and we had published this in the Indian Journal of Pathology and Microbiology. These are my references. Thank you.